our final presentation of the day, we're going to look at newborn screening state experience in Ohio. Please welcome Dr. Margie Ream from Nationwide Children's Hospital.
Great, thank you. It's a pleasure to be here, and I know that I'm the last event of the day, so thank you for hanging in there with me. I'm pretty sure we'll be done by 5. So I'm presenting on behalf of Ohio, but I'm a child neurologist at Nationwide Children's in Columbus, Ohio. I do have to say that I'm a member of the evidence review group for the ACH-DNC. I'm also on the advisory committee for Ohio's newborn screening lab. So a few cartoons here that I sprinkled in throughout the rest of the next few slides. And how does an electric plug and a jar of jelly beans have to do with ALD screening? Well, one family member already brought up a jelly bean earlier today, and I'll wait till the end of the talk to see how that connects. But in Ohio, we have approximately 130,000 births annually that has been decreasing over the last several years. Lab testing is performed at the Ohio Public Health Newborn Screening Lab just outside of Columbus. Columbus is in the center of the state. In this red county here, this is a heat map of population density. We are a one-screen state, and most of our screens are collected 24 to 48 hours of life and arrive at the state screening lab within 48 hours of collection by courier. We do allow religious exemptions, and about 27 out of 100,000 infants do go down the route of opting out of all of the screening. And only about 0.1% of our samples are rejected as unsatisfactory, and in that case, we do try to collect another sample. RUSP adoption is not mandatory, but the advisory committee is required to vote on conditions that are added to the RUSP within 6 months of the secretary adding them to the RUSP. So the committee votes and recommends to the state director of health, which then has another 6 months to put it into law. A positive metabolic newborn screen, including ALD, leads to an urgent referral to one of 7 regional genetic centers, which are highlighted here in the blue. Everyone in the state lives within about a 2.5-hour drive of one of these centers. Newborn Screening Lab does attempt to obtain a final clinical diagnosis for up to a year. If there's not a final clinical diagnosis, or if it's an uncertain diagnosis, or the patient just has not continued to follow up and doesn't actually have a diagnosis yet, the case is closed. Ohio has no long-term follow-up. So the Ohio Advisory Committee recommended ALD be added to our screen in March of 2017. We started universal screening in October of 2022. So here's where the electricity comes in. Our lab needed additional power sources for the new equipment needed to run the ALD screening. Well, with any sort of work like that, it requires going through government contracts and bidding, and then we had COVID, and everything just got tremendously delayed. And the beginning of that delay was our need to upgrade the electrical system. But we did finally start newborn screening. Samples are received on day 3 of life and usually reported out by day 8. XALD results are not called out on Saturdays. None of our results are called out on Sundays or holidays. We use a test method where we measure C26 by QSite. I'm learning about some of this laboratory science thanks to some of you in the audience. So we do use a negative injection. We use liquid chromatography tandem mass spec. It is a single tier test if it is abnormal. So if it is greater than 0.18 micromolar, then the same assay is rerun. And if it is still out of range, then that is considered a positive test. So here is our mean, median, and standard deviation, as well as our minimum and maximum that the lab has seen over the months that we've been doing newborn screening. If the screen is positive, the child's primary care provider, as well as the regional referral center for their area, are notified, and the PCP and the Genetics Center coordinate who's going to notify the family and get them in. We do try to get them in within 2 weeks for an ALD newborn screen. The family meets with a genetic counselor or a geneticist to initiate the confirmatory testing, which involves repeating very long-chain fatty acids and genetic testing if that is abnormal. At least at our center, we're using a panel for the most part. If testing is suggestive of ALD, then the children are referred to endocrinology and neurology. I see them pretty quickly so that the families are not waiting and waiting and waiting, and then explain the idea of doing an MRI between 12 and 18 months. The regional genetics centers are responsible for informing the newborn screening lab of the final diagnosis of ALD, ALD carrier, other, or unaffected. We did start pilot screening in 2021, and then full screening was implemented, and it was officially reported out on the newborn screening test results in October of 2022. So any cases that screened positive during the pilot phase were called out to regional genetics centers, and those children are still seen. So in total, we've screened just over 136,000 infants as of the end of January. Here's our breakdown of race and male and female. This is fairly representative of the demographic in the state. Here's our breakdown of the actual test results. So we have had 25 positive screens. Of those, 8 were female and 8 were male and 17 were female. So the breakdown of males and females screened was very close to 50-50. So I think this is just sample size issues. We just need to keep screening more to have a more even distribution between males and females that screen positive. We've had 1 boy diagnosed with ALD, 1 boy diagnosed with Zellweger, 6 females diagnosed as carriers, a total of 4 unaffected, and then we have 13, or almost half of our positive screens are still pending. We have about half of any positive newborn screen case for any condition in the second half of 2022 still pending. And part of that is because of staffing issues in our lab. And I know I was talking to many of the other state newborn screening lab representatives last night at dinner. Staffing and funding are perennial issues. And for us, it's really hit us in the follow-up department. We have 1 follow-up nurse. We are supposed to have a minimum of 3. So there are probably quite a few people out there, children out there, that have had diagnoses that our state lab just isn't aware of yet. So per 100,000 screened, we have had about 18 positive newborn screens, almost 6 diagnoses of a paroxysmal disorder or carrier status, and that's all comers, male and female. For ALD specifically, for 100,000 males, there's been a diagnosis of 1.5 per 100,000, which brings our incidence very high, or very low, I guess, of almost 1 out of 70,000. I anticipate this will come closer to what has been seen in other states as we continue to screen and continue to enter those final diagnoses into our lab's database. For females, we have a carrier rate of 9 per 100,000, or an incidence of 1 per 11,000. Our positive predictive value for any disorder or carrier status is 0.67, and for XALD specifically in males, 0.25. It's likely that some of the pending cases do have diagnoses that have already been made and that those individuals are already in appropriate follow-up care, but I don't know that yet. And as I mentioned, our male to female ratio is not what we'd expect it to be, but might move closer to the expected distribution as we continue to screen more people. So finally, the jelly beans. Our one case, this is a story of our one case that the lab is aware of has been officially diagnosed. And literally in 2021, the lab was working on optimizing the equipment, training some staff, and they literally reached in and grabbed some newborn screening cards, basically just a handful, a couple thousand, I think, and ran those through the machine, and voila, one screened positive, and that individual has a VUS in ABCD1 that is predicted to be pathogenic, and so he is in appropriate follow-up care. And I think that this case highlighted to our newborn screening staff what an important job they do. And just those few cases, if they had decided to do it on a different day or reached in a different part of the stack, that individual wouldn't have been diagnosed. And so I really want to give a hats off to our newborn screening lab heroes in Ohio, particularly Sharon Leonard and Rashmi Gar, who provided the data for me. And they work endlessly with a lot of understaffing and underfunding, like many of our newborn screening people in the room do, to try to bring the best healthcare to the people, the babies in our state. So that is, I promised I'd get you out of here by 5. That's all the slides I had to present, but I'm happy to answer any questions about how we do things in Ohio. All right, great, thank you. Have a good evening, everyone.